So let us discuss the 20 questions we had from surgery. So I had made some concepts, very important, interesting concepts suitable for NEET PG. So the first question is on Mrs. Rama, 40 years female, operated for fibroid uterus by laparoscopy. Okay, please understand this concept is related to laparoscopic diathermy injuries. Okay, it is related to laparoscopic diathermy injuries. This is one of the favorite topics of National Board. Just have an idea about this topic. Even if you have not read before, just understand. I'll tell you the points. She was discharged on 3rd post-op day. She presented to hospital on 5th post-op day with a diffuse guarding and rigidity all over the abdomen. So a patient underwent laparoscopy, coming back with a guarding and rigidity. So any surgery which is done laparoscopically and patient comes to you after 3 days or 4 days with a peritonitis. So this is a classical case of peritonitis. So on CT abdomen, a diffuse collection of fluid seen in the abdomen, and radiologist gave a suspicion of bowel leak. So this is diathermy injuries. Usually diathermy injuries will not present immediately. The patients usually go home and they will come back to you on 3rd day or 4th day with a leak from the burnt bowel. Okay, that is what happened. During surgery video review, we usually have a recorded video. The surgeon noted that he touched, this is a classical point, that he touched the needle holder with a monopolar hook without noticing. Okay, so with the needle holder, this is a needle holder. For example, this is needle holder. Okay, needle holder in laparoscopy is fully metal instrument, and with the monopolar hook, this is a hook which will be always sheathed. Okay, this hook will be sheathed, and this is metal. So now, if I am going to pass current in this hook, the current will only come in this tip. So therefore, if I'm going to cut a tissue, I will cut with this tip only. By chance, if I am accidentally touching this hook over the needle holder is a metal, it will transfer current to any bowel lying like this nearby, and we will not recognize it. And this bowel, sorry, this bowel gets burnt, and this goes for leak after few days. So this injury is called what? So there are 2 injuries given in New Bailey. One injury is this. What is this injury? This is an injury called as, so welcome. So please answer the question. Yes, excellent, Dr. Sharp. It is direct coupling injury. That is correct. It is a direct coupling injury. Injury which is due to a metal instrument is touched by a diathermy without our knowledge. So the current has come from here. Current has come from this hook to needle holder, a needle holder to bowel. Bowel got burnt. So the patient comes to you after 3 or 4 days with a peritonitis. That's a classical question. Direct coupling injury. So there is no such injury called as indirect coupling injury. There was one old injury known as capacitance coupling injury. It is no more seen. So earth plate is not the reason for this. Earth plate, if not kept properly, diathermy will not work. There are only 2 injuries. One is this injury, and I will show you what is the other injury. See, this is a picture showing you the defect in the insulator. This is a monopolar hook you are seeing here. In the monopolar hook, there is a defect in the insulator. The current spreads from this insulator to this bowel. Okay, that is what happens. This is one type of injury very commonly seen in developing countries like India, where we use old instruments repeatedly. So those instruments, there will be damage of the insulator. So current will come like this and attack the bowel. So this is insulator defect injury, number 1. Number 2, this is the image-based question for your exam. Image-based question showing you direct coupling injury. You can see a monopolar current going via this sheathed instrument, and as I am touching with the tip with the needle holder or any metal instrument. So this laparoscope itself is made up of metal, and that is touching the bowel. There is a burn happening here in this bowel. This is direct coupling injury. Okay, so this is a classical 2 injuries: insulator defect injury, direct coupling injury. These are the 2 commonly seen diathermy injuries in laparoscopy. There was one old injury from 27th edition Bailey. Luckily, that was removed in 28th edition. 28th edition is not showing this capacitance coupling injury. This is not seen because this type of ports we are not using. So if I'm using a laparoscopic, this is a laparoscopy. If I am using a metal port, this is a metal port. Okay, this is metal port with a plastic cuff. This is plastic. This is made up of plastic cuff. If I am passing an instrument through this metal port, the insulated instrument will develop a current called as capacitance current. That current developed here is called as capacitance current that will transfer to the metal port and will touch the bowel. Once upon a time, this is a very famous question. Capacitance coupling injury was once upon a time a very common image-based question. Luckily, this is not seen nowadays because we are no more using a metal port with a plastic cuff. You should either use fully metal, either use a fully metal port, that is what we are using in India, or fully plastic disposable port, which is used in Western countries. So fully disposable plastic port. When I fully use a metal port, the current which is capacitance current which is generated, no, that will go via this to the earth plate. So please understand the three types of injuries in diathermy. So don't forget the three injuries. Diathermy induced bowel injuries, insulator defect injury number 1 is very common in developing countries due to using of the same instrument for long period of time. Direct coupling injury by touching a metal object. Capacitance coupling injury is obsolete now. It is not there in Bailey and Love, but this image will make you understand when I use a metal instrument with an insulator sheath through a metal port with a plastic cuff, the current will be generated. This is a capacitance coupling current. When you go back to your physics days, you will understand this. The current will be generated in this port and this will transfer the current to the bowel. So please don't forget. Yes, it will be staying alive. Don't worry. I will ask them. You can see this just 1 hour. You can observe. I'm just going to discuss 20 important concepts. This is related to diathermy induced bowel injuries. Okay. So what about that bowel leak? So treatment of bowel leak is immediate laparotomy. No more discussion at all. So when there is a bowel leak in a laparoscopy case, we have to operate as early as possible. Otherwise, patient will go for peritonitis and the patient will die. So this is like a perforation case only. Okay. Second question is related to total parenteral nutrition by a central venous catheter. Mr. Kumar, 25 years male, operated for mesenteric trauma. Around 400 centimeter of small bowel was removed 1 week back. So he went into short bowel syndrome. He came to hospital now with a diarrhea, steatorrhea, hyperacidity. So he was planned TPN and the cannulation was done via the subclavian vein. After 30 days of TPN, patient is on TPN for 30 days. He is now coming back to you with a fever. Which of the following statement is false on this case? So please understand. What about this question? What is this concept? See, when you are appearing for any NEET PG question, you have to put the following questions. Number 1, have you read this concept? Have you read this concept in your preparation time? Have you read this concept means yes. This concept is TPN bar central vein complications. Have you read this complication? Then only you should attend the question. Second point. So then you attend. If you have read the concept, you read the further choices. Second point is, can you rule out 2 choices? 2 choices can be removed by you. You have understood the concept and you can say 2 answers are not correct. Then only you should attend. Otherwise, don't attend. Otherwise, definitely it will go for negative mark. Don't try to attend with the guesswork. Definitely it will not work. So please remember, this is a protocol you should follow. Have you read this concept? Any question? Yes means you attend, read further. Otherwise, no use of reading. If you have not read this concept means don't worry. Just skip that question and go further. Other question which is easy because you have only 42 minutes time for a 40 question. So you have to keep on moving fast. Okay. Traditional method of confirming catheter related sepsis. Once upon a time, we used to remove the catheter, cut the tip and send for culture sensitivity. This is an old method. Yes, it is true. Recent trend is now we don't remove the catheter. We do a endoluminal brush culture sensitivity and blood culture sensitivity. You should do culture sensitivity from the tip, brush and blood culture sensitivity. Both shows same organism is done now. True. Colony count. Another method is instead of doing a brush cytology, you can withdraw the sample from the central vein. And if the number of bacterial count is 5 times that of peripheral blood, it is confirmed. That is also true. So since same catheter can be used after giving antibiotics as per culture sensitivity report is absolutely wrong. See, central venous catheter. Please don't forget the concept of answer is D here, not C. Answer is D here. So central venous catheter related sepsis. This is a very favorite topic of examiners. catheter-related sepsis commonly presents to you with the complaints of pain at the catheter site. Patients will tell pain at catheter site, and patients will also have fever. Pain at catheter site and fever will be present for the patient. And now what should I do? I should look for temperature is increased, clinical examination, temperature increased, pulse rate increased. But please remember, a patient who is already sick patient on TPN may have fever due to many reasons. I want to know whether it is only because of this catheter. So what will I do now? Recently, we are aspirating central venous blood for culture sensitivity, peripheral venous blood for culture sensitivity. If both are same organism, it is confirmed. Okay, it is same organism means it is confirmed. Another method of testing this is by means of colony count. Colony count is more than 5 times from the central vein than the peripheral vein. It is positive. So that means what? The central venous catheter got infected. So what is the treatment for this case? Yes, excellent, Mukesh. That is correct. That is absolutely correct. Remove the catheter and put new catheter on opposite side. That is a classical answer. Opposite side, you should put a new catheter. You remove this catheter from the right side and put a new catheter on the opposite side. That is answer for this question. Answer is D. Don't forget central venous catheter sepsis related question. So I'm not discussing in detail about everything, but I'm discussing only the questions because this is a 2020 series. We have to know what is the concept, how to answer the concept. That's all. So the answer for this question is same catheter can be used is wrong. We have to remove the catheter and do a new catheter. Send tip for culture sensitivity is a old concept. Okay. So old concept is we send the tip for culture sensitivity. Now it is not needed. Okay, not needed. So now coming to the third question. This is a very favorite topic of national board examiners, and especially nowadays surgery is moving towards day case surgery. So day case surgery means what? Day case surgery means surgery, a patient get admitted and discharged within 12 hours. Within 12 hours, if you admit, operate, discharge a patient, it is called as day case surgery. So this is a very classical MCQ. Day case surgery is a favorite topic of national board examiners. Patient admitted at 8 a.m. and discharged at 8 p.m. That is called as day case surgery. Which of the following factor will make him unfit for same? It is not same as, it is unfit for daycare surgery. Unfit for daycare surgery. BMI less than 40, we can do daycare surgery. Number one. BMI less than 40, we can do daycare surgery. Surgery timing is less than 2 hours, we can do daycare surgery. After discharging the patient, please remember the patient should not go home to his native place. He should be available within 2 hours from the hospital. For example, that is why when you go to Apollo hospitals and all in Chennai, you can see many guest houses will be available nearby Apollo hospital. Following a daycare surgery, the patient will be staying within 2 hours. That is for daycare purpose. So within 2 hours, not more than 2 hours. Patient should be able to come to hospital within 2 hours in case of any emergency. No upper limit for age can be done at any age is the indication. So the answer here is C. Now this is the definitions from Bailey and Love, New Bailey and Love. Outpatient surgery is not admitted to a ward facility. Procedure room surgery is not requiring any theater facilities at all. You can do IND in a general ward, open theater itself. Day or same day surgery is 12 hours stay. So same day surgery and day care surgery are same. Overnight stay is 23 hours admission. Short stay surgery is 3 days. Okay, don't forget these points. So 23 hours is overnight surgery. 3 days is short stay surgery. Day care or same day surgery is only 12 hours. This is a very important table you'll get in your exam. So selection criteria for daycare surgery involves ASA status of more than 2 requires careful review. So provided BMI is under 40, this alone is not a contraindication. A responsible adult should be available for first 24 hours and ability to contact hospital in an emergency. Operations should be done up to 2 hours, and this is a made points from Bailey and Love. So all you can take for surgery. BP less than 110, 180 or 110. HbA1c less than 8.5. Epilepsy is not a contraindication, but don't omit the tablets preoperatively. BMI up to 40 for open surgeries and 38 for lap surgeries. So travel time should be within 1 hour, surgery time should be within 2 hours. So this is what we expected in MCQ. So for a daycare surgery, what all conditions? Hypertension is not a contraindication. BP should be less than 180/110. Diabetes is not a contraindication. HbA1c should be less than 8.5. Should be less than 8.5. Epilepsy is not a contraindication. BMI up to 40 is not a contraindication. Travel time within 1 hour. Surgery time within 2 hours. These are the important points you should not forget related to daycare or same day surgery. So that's a third question, concept on third question of daycare surgery. Okay. So fourth concept is related to damage control surgery. Fourth concept is related to damage control surgery. So damage control surgery is done in trauma, road traffic accidents. When a patient is having excessive bleeding or excessive sepsis, we will control it as early as possible by a simpler procedure. That is what called as damage control surgery. Mr. Gupta, 30 years male, faced a massive road traffic accident and admitted in ICU for multiple fractures. He was planned for damage control surgery based on following facts. Which among the following parameter is not an indication of damage control surgery? So excellent, Dr. Shah, that is correct. Injury severity score more than 36 is an indication of damage control surgery. So the answer is A. BP low, lactate 5 millimoles or more, blood transfusion 15 units, pH less than 7.2. So this is very simply mentioned as deadly triad of trauma. Deadly triad of trauma is an indication of damage control surgery. What are the deadly triad? HAC. Hypothermia. When a patient is having hypothermia, acidosis like pH less than 7.2, coagulopathy. So these are three important indications for a damage control surgery, and there is a classical table from Bailey and Lowe. Hypothermia, acidosis, coagulopathy is an indication of damage control surgery. Serum lactate level is a very important predictor. If it is more than 5 millimoles, damage control surgery is done. If it is less than 2 millimoles, yearly total care can be done. So opposite to damage control surgeries, you can do a definitive surgery known as yearly total care can be done for less than 2 millimoles, BP less than 70, transfusion 15 minutes, injury severity score more than 36. This is a classical question, favorite national board question. Please don't forget, damage control surgery. In Bailey, there are 5 stages of damage control surgery. Number 1, identify the patient suitable based on this table. Number 2, shift him to emergency OT. Don't close the abdomen after the procedure. After the operation, don't close the abdomen. Just keep a plastic sheet. Shift to ICU. Third step. Fourth step, you plan for surgery after 48 hours after emergency surgery. You will plan for elective repairs under the control of professors and chief of the department. You will do elective procedure at 48 hours, and last we close the abdomen. So this is 5 stages of damage control surgery from Bailey and Lowe. Repeated MCQ. How many stages are there in damage control surgery? There are 5 stages. Stage 2 is emergency OT. Stage 3 is ICU. Stage 4 is elective OT. Stage 5 is closure of abdomen. So this concept is related to diagnostic peritoneal lavage and EFAST. So you all know what I've seen. These are 2 important concepts in trauma. Diagnostic peritoneal lavage is nowadays replaced by EFAST. Nobody is doing diagnostic peritoneal lavage except only one indication is now. Otherwise, mostly EFAST is done for blunt injury of abdomen. So in a diagnostic peritoneal lavage, what are the things to be positive? So can you answer the question? In a penetrating trauma, more than 10,000 RBC is positive in DPL. FAST cannot detect less than 100 ml fluid. Retroperitoneal injuries cannot be detected by EFAST but can be detected by DPL. DPL is extremely useful in hypotensive, unstable, multiple injuries to rule out abdominal injury. This is the only indication of DPL in 2024. In 2024, the only indication of DPL is patient is dying. You cannot take him into any further management. So this is extremely useful in hypotensive, unstable, multiple injury patients to rule out abdominal injuries. Urine dipstick is available. Instead of going for a lab value, you can also do urine dipstick may be used in the absence of lab facilities from aspirated fluid. So which is wrong in this? Question is, which is wrong? C is wrong, not D. C is wrong. Please understand. Diagnostic peritoneal lavage. It can detect pathology only inside the abdomen. How can it detect pathology outside the peritoneal cavity? This is peritoneal cavity. Retroperitoneal means like aorta, IVC injury, you cannot detect. So IVC, aorta injuries and all you cannot detect. You can only detect bleeding within the peritoneal cavity in both DPL as well as 𝗵𝟏. In both the conditions, you can detect bleeding into the peritoneal cavity only. You cannot detect what is there in the retroperitoneum. Both are not useful for retroperitoneal injuries. Very important. DPL as well as 𝗵𝟐 both are not useful for retroperitoneal injuries. So please remember this point, first point. And 𝗵𝟐 is not useful for following. 𝗵𝟐 not useful in blood in the peritoneal cavity less than 100 ml, not useful. Bowel injuries, not useful. Penetrating trauma, no use. And number 4, in case of retroperitoneal injuries, it is no use. So 𝗵𝟐 is not useful in less than 100 ml collection, bowel injuries, penetrating injuries, and retroperitoneal injuries. Okay, please don't forget this point. And DPL is said to be positive if there is more than 1 lakh RBC. 1 lakh RBC in a blunt trauma or more than 10,000 RBC in a penetrating trauma. Okay, please don't forget. That is the first point. DPL is said to be positive with more than 1 lakh RBC or 10,000 RBC in a penetrating trauma, more than 500 WBC, presence of bile or food particles, and presence of amylase increased. All these are findings to say that is DPL positive. So don't forget this point. DPL is diagnostic peritoneal lavage. See, this is a revision class for NEET PG. Those who are going for NEET PG, please attend this session. Those who are not preparing presently for NEET PG 2024, this session might be very fast and you might not be understanding. Please go through our doctoral full lectures. You will understand everything in detail. This is just for those students who are preparing for NEET PG 2024, who are going to appear for exam in 15 days. This will be helpful. This is not for FMG also. Very clear. I'm clear. This is not for FMG. This is only for NEET PG 2024 students. Others, you relax and prepare gradually. Okay. So this is a classical concept on diagnostic peritoneal lavage and 𝗵𝟐. Please remember about it. This is a line from Bailey and Love. The presence of 1 lakh RBC or 500 WBC is deemed to be positive in a case of diagnostic peritoneal lavage. So diagnostic peritoneal lavage, although DPL has largely been replaced by 𝗵𝟐, it remains the standard in many institutions where 𝗵𝟐 is not available or unreliable. DPL is especially useful in hypotensive, unstable patients with multiple injuries as a means of excluding intra-abdominal bleeding. Okay, please remember this. Question number 6 is on retroperitoneal hematomas. This question is already asked. AIMS question. Retroperitoneal hematomas. Which of the following injuries shown in the image you must never try to operate and plan only for non-operative method? So please understand these retroperitoneal zones are 3 zones available. I'll redraw the zones. Zone 1 is a zone where there is aorta as well as IVC. Zone 1 is aorta and IVC. This zone is called as zone 1. Zone 1 is aorta IVC zone. This is an emergency zone. Immediately you have to operate. Immediate surgery should be done. Immediate surgery should be done and you should do Mattox maneuver for aorta, Kettle maneuver for IVC injuries. Don't forget, these are very common questions. Mattox maneuver should be done to expose the aorta, that is left viscera rotated medially. Kettle-Brash maneuver is rotated to the right side to see the IVC, that is immediate surgery. Zone 2 is for kidney injuries. So this is zone 2. This is zone 2 for renal injuries. So most of the time, these patients will be managed by non-operative method. Zone 3 is pelvic hematoma. Zone 3 is pelvic hematoma. Please remember. Pelvic hematoma is very difficult to stop by surgery. Don't do surgery. Just put binder. Just put binder and pressure. Don't do surgery. Zone 4 is a zone behind the liver. Okay. Zone 4 is retrohepatic IVC injuries. This retrohepatic IVC injuries is called as zone 4. It is not from Bailey, it is from Sabiston. So please don't forget, zone 1 is IVC and aorta injury. We need to operate immediately. Zone 2 is an injury of kidney. You can do non-operative method as well as surgery. Zone 3 is pelvic hematoma. Never do any surgery. Zone 4 is retrohepatic IVC injury. We may operate. So which zone does not do surgery means zone 3, you will just keep a pelvic binder. So this question is already asked, Ames question. Please don't forget from Bailey and Law. So question number 3, I have finished the basic concepts from general surgery and trauma. I have took 6 questions. Now I am going to head and neck, thyroid and breast. So Mr. Gunal Gupta, 50 years old male, severe beetle nut tumor presents with a painless ulcer in the tongue and swelling in the left side of the neck. So this is a case of oral cancer in the tongue with the left side node. Okay, node is also there. On examination, ulcer is 3 into 2 centimeter size and node is 3 into 2 centimeter size. So on evaluation of the patient, what are the investigations done for a oral cancer? So oral cancer, very common cancer in Indian males. Please remember, it is one of the common cancer in Indian males. Which of the following is false about oral cancer? See, first of all, I want to tell you which investigation should be used for soft tissue cancers. Soft tissue cancers like oral cavity, parotid, we will go for MRI for staging. For soft tissue cancers like oral cavity cancer, tongue cancer, parotid cancer and all, we will go for MRI. Bony involvement like maxilla cancer, mandible involvement in cancer, we should go for CT scan. So don't have any doubt in this. So, and retroperitoneal cancers like pancreas, kidney and all, which is best? It is CT scan is best. CT scan is best for retroperitoneal cancers. Whereas coming to biliary, bile duct cancers, GB cancers, these cancers will go for an MRI. Okay, this is went for MRI. Okay, this is some, every cancer there will be some investigation for radiological investigation for staging. So please remember, the question is telling about oral cancer. Short tau inversion MRI is done after tissue biopsy. So yes, MRI should be done not after, it should be done before tissue biopsy, because when you do a tissue biopsy, that inflammation because of the biopsy will be looking like an infiltration. Therefore, if you are going for a radiological, this is the basic. If you are going for a radiological investigation and pathological investigation, which one will you do first means always do radiological investigation before going for a needle or true cut. Same in breast also. In breast also do mammography, then you send for biopsy. We don't do biopsy and send for mammography. Same concept is not done before tissue biopsy. It's done after. Biopsy should be done only after MRI. Okay, this is first point. Bony invasion CT is advised. Tissue diagnosis done by incisional biopsy, and for the node you can take FNAC now. Latest update is node can be confirmed by FNAC. So the answer here is A. So don't forget, oral cancer is a favorite topic for exams. So definitely the examiners may ask you T1, T2, T3, T4. Please go through staging of oral cancer and breast cancer. 2 cancer staging you should always read. That's very important for your exam. So T1 less than 2 centimeter, 2 to 4 centimeter, more than 4 centimeter. T4A is removable oral structures. B is non-removable oral structures. Non-removable means carotid artery, vertebra, all those things come under non-removable. And now they added depth of invasion less than 5 mm, depth of invasion 5 to 10 mm, depth of invasion more than 10 mm. This is coming under T staging. So this is T staging. So don't forget N1, N2, N3. So any node less than 3 centimeter is N1. So N2 is 3 to 6 centimeter nodes. More than 6 centimeter node is N3. So in N2 you have N2A, N2B, N2C. So single node 3 to 6 centimeter. Multiple ipsilateral node on one side 3 to 6 centimeter. Multiple bilateral nodes on both sides 3 to 6 centimeter is N1. So don't forget these two stagings, T staging, N staging, and M staging is METs. So this is very favorite topic. T&M staging of oral cancer and breast cancer can come for your exam. Please go through that staging. And don't forget the investigation of choices MRI for oral, oropharyngeal, neck cancers. And always, ideally, it should be performed before biopsy. MRI should be performed before biopsy. Okay. So 8th question, Mrs. Kumari, 25 years female, presents with a thyroid swelling, complaints of diarrhea. See, this is a classical question. Thyroid swelling with a diarrhea. On examination, she gives history of her mother died due to some cancer inside the abdomen. And on evaluation of this girl, FNAC showed this finding. What is this finding showing here? It is amyloid stroma. You can see the amyloid stroma. Amyloid stroma is a classical finding of what cancer? Can you tell me what is this cancer? It is medullary cancer thyroid. So medullary cancer thyroid is the least common thyroid cancer. Don't forget this first point. So medullary cancer thyroid is the least common thyroid cancer. It is not associated with MEN1. It is associated with MEN2A, MEN2B. So can you tell me the answer for this question? What is the answer for this question? Yes. Yes, very good, very good. That is medullary thyroid cancer, Dr. Shah. Lymph node involvement is seen in 50% case. That is true. And associated with MEN2A, MEN2B. Most common METs is not to lungs, it is to liver. Okay, so that is to liver. Most common site of metastasis from medullary cancer is to liver. Tumor is not TSH dependent. Which tumor is TSH dependent? That is papillary cancer is TSH dependent. So which answer is correct here? So the answer is C. C is the correct answer here. All others are false. It is associated with the MEN2 syndrome. It has liver mets. And it does not show increased uptake with radioactive iodine. Radioactive iodine uptake is only with the papillary cancer. So why this history is very important? If you see her mother died due to some cancer in the abdomen, what abdominal cancer her mother would have had? Anybody? MEN2A, MEN2B syndrome. This is a case of MEN2A, MEN2B. What cancer mother would have had? Can you tell me? 100% they develop medullary cancer thyroid. 40% they will develop what cancer? Anybody? What is the second common cancer in MEN2A, MEN2B? Yes? Pheochromocytoma. This is the case of pheochromocytoma. Probably her mother died of adrenal pheochromocytoma. So therefore, this is a case of medullary cancer running in the genetic family, not pancreatic, pheochromocytoma. MEN1 only will have pancreatic cancer. So MEN2, MEN2A, MEN2B, MEN1, please go through thoroughly. So very important. So mother was having a previously pheochromocytoma. Now daughter has come to you with the medullary cancer thyroid, and the tumor marker is calcitonin. Very good. It is calcitonin. Calcitonin is the tumor marker. Yes, very good. That's correct. Okay. So please remember, medullary cancer is the least common, 2.5%. So medullary cancer is having 50% have lymph node mets. Most common site of distant mets is to liver. Tumor is not TSH dependent and does not take up radioactive iodine. It is papillary cancer which is TSH dependent. Okay, familial type is 20% and it is common in families. So coming to question number 9, 45 years obese premenopausal woman, Mrs. Rani, presents to breast clinic. On routine mammography, she is found to have 5 into 4 centimeter lesion, 5 into 4 centimeter lesion in the breast with a multiple axillary nodes fixed to each other. So definitely this is staging you will be definitely reading. The diarrhea is because of the tryptophan produced by this. So medullary cancer produces many hormones. Medullary cancer is a neuroendocrine tumor. So it produces serotonin. It produces serotonin, CEA, histamine. Therefore, these patients will have diarrhea. These patients will have ACTH production. Therefore, they can have Cushing syndrome. Many findings will be there in medullary cancer. Medullary cancer is a favorite national board topic. Please go through that. Okay. So this lady is now coming to you with the tumor in the right breast with the multiple fixed axillary nodes. Clinical examination also reveals she's having multiple nodes. The classical catch point is here. True cut biopsy shows lobular cancer of breast. It is a very rare cancer, less than 10%. IHC was done ER negative, PR negative, HER2 positive. Which of the following is wrong regarding this case? Yes, can you tell me which is wrong? Opposite breast must be evaluated for cancer by FNAC. Why? Why should I do an FNAC of opposite breast? Can you tell me? Why should I do FNAC of opposite breast? Please remember, lobular cancer is having 5 important MCQs. Lobular cancer is a rare cancer compared to ductal cancer is common. Lobular cancer is very rare, but interesting point, it is bilateral. It is mostly bilateral, and biopsy shows what finding? Biopsy of lobular cancer shows Indian file pattern of arrangement of, yes, very good. Indian file pattern of arrangement of cells are seen in lobular cancer, and since it is bilateral, opposite side MRI and biopsy needed. Opposite side breast evaluated. Please remember, lobular cancer is multifocal, multicentric. It is seen in both the breast, any quadrant, it can be seen. Therefore, treatment of choice is bilateral MRM for this case. Bilateral MRM should be done for this case. So, answer for this question is opposite breast must be evaluated. True. The patient must be advised to tamoxifen. Who will you give tamoxifen? Tamoxifen is given only when there is ER positive. The case is very clear, ER negative. So, no tamoxifen is needed for this patient. Breast conservative surgery is contraindicated. Yes, I told you the cancer is multicentric, multifocal. So, there is no role of breast conservative surgery. Ideal treatment is bilateral MRM plus trastuzumab because patient is HER2 positive case. See, breast cancer, there will be definitely 1 or 2 questions. You should be thorough with the concepts of breast cancer. So, this is very important point. Don't forget. So, this is a lobular cancer, very less common, less than 10%, multicentric, multifocal. And you can see the arrangement of cells in an Indian file pattern of arrangement of cells. You should do bilateral MRM. Okay. Question number 10. Mr. Ramu, 25 years male, manic depressive illness. Every word in the clinical questions will have an impact and has renal stones, pancreatic stones. What does it mean? He was evaluated in the neck. He is having a left inferior parathyroid gland. Sestami B scan showed another nodule in the upper part of the neck. See, this is a case of bones, stones, abdominal groans, and psychic moans. So, bones, stones, abdominal groans, and psychic moans is a feature of which condition? It is a feature of hyperparathyroidism. Hyperparathyroidism, the most common causes adenoma from the parathyroid gland. That is the question. So, the adenoma is evaluated by 2 tests. Technetium 99M Sestami B scan and ultrasound of the neck. These are the 2 investigations that should be done. Now, Sestami B scan showed 2 nodules, whereas ultrasound showed 1 nodule, that is in the left inferior. We are planning to do surgery, which is the false statement from the statement given below. See, all questions may look tough, but don't worry, the exam will not be this much tough, but you should understand the concept. That is why I made each question in depth. So, understand the basic concept in each topic. False positive MIB scan is associated with Hürthle cell adenoma. Hence, technetium 99M subtraction images are obtained. This is a very interesting point you should never forget. When I do only Sestami B scan for a thyroid, for a neck, what will happen? The parathyroid, any adenoma will be picked up. This is parathyroid, adenoma will be picked up. But simultaneously, if there is Hürthle cell adenoma, that also will be seen. Hürthle cell adenoma is a false positive image. It is due to rich oxyphil content. Due to rich oxyphil content in the Hürthle cell adenoma, they will be seen. Therefore, what is ideal? If I do technetium 99M subtraction scan, this Hürthle cells will disappear and I will only see the adenoma. So, therefore, this is the investigation of choice to locate is technetium 99M Sestami B scan. Immediately, you should do a ultrasound and confirm the swelling. Ultrasound neck, confirm there is a swelling in the same location. Yes, there is a swelling in the same location. So, if there is a location, same swelling, I can easily operate by doing a small surgery known as 3 centimeter incision I can put and I can do MIP, minimally invasive parathyroidectomy. The Sestami B scan shows 1 nodule. Ultrasound also shows 1 nodule. I will put a 3 centimeter incision and remove that nodule alone. After removing the nodule by MIP, I will do Miami criteria. What is Miami criteria? After removing that nodule, I will test for parathyroid hormone level. It should fall more than 50% in 10 minutes. From the previous value, it should fall more than 50% in 10 minutes, means your treatment is over. Treatment is over. If it is not falling, Miami criteria failed means I should open the full neck and remove all 4 glands. All 4 glands are removed and 1 gland kept in forearm. Okay, in forearm. This is a classical MCQ point. Don't forget this. Now come to the question. Discordancy in images is evaluated by CT scan. Minimally invasive parathyroidectomy with a 3 centimeter incision is enough and no further evaluation needed. Bilateral neck exploration and removal of all glands with the leaving of left 1 gland is preferred with the marking of non-absorbable. Either you remove all the 4 glands or leave half of the gland in the neck itself. Anything you can do. But there are 2 surgeries. One is minimally invasive parathyroidectomy. Another is bilateral removal. Okay, that is a point. This is a flow chart. So the answer here is minimally invasive parathyroidectomy with a small incision of 3 centimeters enough is wrong. How it is enough? It is not enough because this patient's system EB scan showed another nodule in the upper part of the neck. Therefore, it is not a concordant image. It is discordant image according to this flow chart. See this picture. This is an ultrasound, shows there is a single adenoma on the left inferior parathyroid. Ultrasound shows only 1 nodule, means I can go for a concordant imaging, go for MIP. Simple image. Concordant image, go for MIP. Discordant image, go for 4-dimensional CT scan and go for 4 gland exploration. If there is a discordant image, we have to go for 4 gland exploration. So parathyroid, when I'm doing surgery, see this question comes where will you keep the parathyroid? When I'm doing a thyroidectomy, I have removed the parathyroid gland by mistake. And surgery is going on and I found I have removed 1 parathyroid gland. During surgery, I will keep it in the 𝗗𝗃𝗃𝗃. If the surgery is completed and I have closed the abdomen, patient shifted to the ward, specimen is containing parathyroid gland, I will keep it in the forearm. See, then I cannot go and open the neck and keep inside. Therefore, surgery is already completed means I can keep in the non-dominant forearm. If surgery is going on, you keep it in the neck itself in the 𝗗𝗃𝗃𝗃. If surgery is completed, patient shifted to the ward, you keep it in the forearm. This is very important point from the parathyroid. Where will you keep? So coming to GIT, question number 11. Mr. Solomon, a Dutch fleet is a gluten used to induce autoemesis. One day while he auto-emitted, Professor Bohr have noted he is having severe pain in his chest and breathlessness. He was evaluated. So what is this concept related to? Anybody? This concept is related to what syndrome? See, as I told you, always find out what is the concept asked in the question. Only when you know about the concept, you attempt the question. If you don't know about the concept, please don't attempt the question. Go for the next question. So this is a case of Bohr-Haave syndrome. Okay, this is a case of Bohr-Haave syndrome. There will be severe rigidity in the abdomen due to esophageal perforation. The leaking contents can reach the abdomen. Severe guarding may be seen in the abdomen. CT scan is required for the management. T-tube drainage of the esophagus with the feeding jejunostomy is done in case of late presentation. So selected patients can be managed by non-operative. Absolutely wrong. There is no role of non-operative management. Please don't forget, there is no role of non-operative management. So Bohr-Haave syndrome. Bohr-Haave syndrome is characterized by Mackler's triad. What is Mackler's triad? Vomiting, chest pain, subcutaneous emphysema. These are the features of Mackler's triad. They may have also associated abdominal pain. So this is a very serious emergency. If you're not going to treat the patient, patient will die. Therefore, immediately admit the patient and you have to do a thoracotomy taking a CT chest. So CT thorax is the investigation of choice. So take a CT thorax and if there is a perforation, take him for thoracotomy and repair the rent. So this is Bohr-Haave syndrome. So only surgery. There is no medical treatment for a Boerhaave syndrome. So Boerhaave syndrome, when you take an X-ray, you can see this finding. It is a radiology question. Can you tell me what is this finding? In an X-ray, very rarely seen. This is called as pneumomediastinum. Air in the mediastinum called as what sign? What is the name of this sign? 値κλέριο V sign. You can see there is a V-shaped gas. This is called as 値κλέριο V sign in Boerhaave syndrome. So please don't forget, whenever you see a Boerhaave syndrome, the one, very good, Alaji and Mukesh, that's correct. So whenever you see a Boerhaave syndrome, immediately operate them. That is a very important basic point. So coming to question number 12 from stomach chapter, dumping syndrome. False statement regarding dumping syndrome after peptic ulcer surgery is rapid gastric emptying is a common feature of early and late dumping. Early dumping is seen in patients after high selective vagotomy. Somatostatin is useful for diarrhea happening in dumping syndrome. Revision procedure of choice is antrectomy with the Roux-en-Y reconstruction. So most of you would have read this chapter on dumping syndrome following a gastric surgery. So for example, this is a gastrojejunostomy done. Now, when your patient is going to eat too much, the food particles will go down and cause early dumping and late dumping. Please go through them. Early dumping happens in 30 minutes. Late dumping happens in 2 hours. The patients will be characterized by diarrhea. One of the important symptoms of dumping is diarrhea. So the question is asking how to prevent dumping syndrome. Prevention of dumping syndrome is by simple concept. Split meals. Don't eat all the food together. So split meals, low carbohydrate meals, okay, increased protein and fat meals, and don't drink water while eating. Avoid water while eating. So these are used to prevent it. But if it is keep on happening, we can go for a drug of choice for dumping syndrome is octreotide. Octreotide is a somatostatin analog. But the point is, octreotide will cause dumping syndrome reduced, but not useful in diarrhea. So not useful in diarrhea. That is the point. So when such dumping syndrome happens, one of the operation we do is we convert this GJ to a Roux-en-Y type of operation. This is Roux-en-Y type of surgery. This is Roux-en-Y. You convert this to Roux-en-Y if that is not responding to these patients. Split small meals, low carbohydrate diet, increase protein and fat diet, avoid water is a rule. So now answer this question. Rapid gastric emptying is a common feature, yes, of early and late dumping. Early dumping can happen in anybody, but it is seen in high selective vagotomy also, but it is less common in high selective vagotomy. Somatostatin is useful for a diarrhea. Yes, no, it is absolutely wrong. Divisional surgery is D. So the answer here is C. So this is a very important table from Bailey and Lau. Don't forget this table. Early dumping is characterized by, yes, it is characterized by hypovolemia. It is characterized by, early dumping is a feature characterized by hypovolemia. So therefore, you should give him more fluid. This patient should be made to lie down. Just take some good amount of food in a split way. Late dumping is characterized by hypoglycemia. Don't forget these points. So it happens usually second hour after the meal, and duration of attack in both the cases is 30 to 40 minutes. So early dumping, make him lie down. Late dumping, just give them glucose. Okay. So precipitating factors are food rich in carbohydrate. Therefore, ask them to take small meals, and you have to ask them to drink water after eating or before eating. Okay, this is very important point. So from obesity, OS-MRS score. This score is highly expected MCQ topic. Obesity surgery mortality risk score. If somebody is coming to you and you are advising them obesity surgery, you should undergo obesity surgery. Immediately, what question they will ask? Sir, will I die during this operation? That will be the question. So you have to immediately put this score. Obesity surgery mortality risk score. 5 factors are taken. Age, BMI, male sex, hypertension, increased DVT risk. Give 1 point for each. For each increase in point, there is increase in mortality. Okay, increase in, this will be available in DocTutorials. You can download the question paper and you can see the explanation, everything in the DocTutorial app itself. So don't worry. This is available in DocTutorial. platform. So age above 45, BMI above 50, male sex, hypertension, and increased DVT risk. So it's not female sex. These are the 5 factors of obesity surgery mortality risk score. Please don't forget these 5 points. Okay, give 1 point for each increased point, increased death. So this question is a classical image-based question, both from radiology as well as from surgery. Mrs. Kamala, 50 years female, with a history of oral contraceptive pill intake, comes with abdominal pain. CT done is shown in the image below. This is a direct image-based question. What is it? CT scan shows what finding here? What is this? That is a classical image you are seeing here. What is that image? Can somebody tell me what is it? If it is FNH, showing central scar. Central stellate scar is a feature of focal nodular hyperplasia. Please don't forget it is FNH. Male sex have more central obesity. So central obesity is a common cause of death. Central type of obesity is common in males. Okay, therefore, there is more common cause. Central obesity is one of the causes of post-operative complications. So this is FNH. So don't forget focal nodular hyperplasia. It is common in middle-aged females. It is associated with OCP intake is present, and this is not gets converted to malignancy. Not gets converted to cancer. So FNH, nothing to worry. Just you have to diagnose it. Once you diagnose it, the diagnosis is made by a central stellate scar like this. So though in the image it is not clearly seen, but the classical finding is scar. FNH has one important finding. FNH is the only tumor in the liver having functioning reticuloendothelial cells. The only tumor in the liver having functioning reticuloendothelial cells called as Kupffer cells is normal in these cases. So only tumor which is normal is this case. Therefore, this can be detected with the help of sulfur colloid scan. It is hot spot. FNH appear as a hot spot in a sulfur colloid scan. Don't forget this. Very good. That is a central stellate scar. You should never forget for your exam. So other tumors also I'm showing you. In a hemangioma, there will be slow enhancement from periphery to center. There will be slow enhancement from periphery to center like this in a hemangioma. Hemangioma is like that. Adenoma shows yearly enhancement like this. And this is a central stellate scar in a FNH. Okay, FNH. So this is a FNH showing you, FNH shows you sulfur colloid scan with a hot spot. I told you the only tumor with a Kupffer cell functioning is FNH. Therefore, it is seen on hot spot. What is this investigation? This is a T2 weighted MRI. T2 weighted MRI shows you what finding it is. It is a classical light bulb sign. Light bulb sign in the liver is seen in hemangioma. Hemangioma shows light bulb sign. So this is 𝗙cie, hepatocellular cancer, shows yearly enhancement, yearly washout. On contrast CT, yearly enhancement, yearly washout is seen. That is a classical finding of 𝗙cie. So don't forget yearly enhancement and yearly washout is seen in 𝗙cie. Sorry, there is a net break. Nothing. Mrs. Rani, who had laparoscopic cholecystectomy 2 days back, now is presenting with the right hypochondrial pain and fever. Urgent ultrasound abdomen revealed a collection of 10 centimeters in the right hypochondrium. Urgent PCD was done and patient is observed in the ward. Which of the following is not a part of this management? Can you tell me what is this concept related to? So this concept is related to what? Concept is post-op bile leak following a laparoscopic cholecystectomy. One of the major complications, post-operative bile leak. So patient comes to you, the post-operative bile leak. The first done investigation is ultrasound. Ultrasound shows collection. You should immediately do a bile percutaneous drainage. So now, how all can I diagnose bile duct injury? Bile duct injury can be detected by all the investigations. Ultrasound, yes. CT scan, yes. KIDA scan, yes. MRCP, yes. ERCP, yes. All of them can detect. Bile leak from the bile duct can be detected by all the investigations. But the speciality is Only 𝗂RCP can detect site of bile leak. Site of bile leak is detected only by 𝗂RCP. Others will find out there is a leak. They will show there is a leak, but they cannot show the site of leak. Site of bile leak investigation of choice is 𝗂RCP. So therefore, other investigations are not much helpful in finding out the site of leak. So HIDA scan is confirm the leak, yes. 𝗂RCP is the best to diagnose bile leak, yes. MRCP may also help us to determine the level of injury, yes. MRCP will help you very well in bile duct strictures. In future, bile duct strictures, it is very helpful. CT abdomen is always done as a part of follow-up in bile duct. So CT abdomen is not helpful after some time. In the follow-up, CT abdomen is not done. So MRCP is always done in the follow-up. So follow-up, it is done with MRCP. So the only question I want you to remember here is 𝗂RCP classification of bile duct injuries is called as Strasbourg. Okay, the answer here is D is wrong, not C. D is wrong. MRCP helps to determine the level of injury and stricture. Not best, but 𝗂RCP is the best, but bile duct strictures, MRCP is helpful. So 𝗂RCP shows Strasbourg classification of bile leak. I hope all of you remember this. This is A. There is a leak from the cystic duct. This is cystic duct leak. This is a most common type of bile duct injury. B and C are due to aberrant duct. This is aberrant duct, okay, not cystic duct. This is aberrant duct injury. Aberrant duct clipped. Aberrant duct clipped is B. Aberrant duct cut is C. D is lateral injury of bile duct. D is lateral injury of bile duct. So there is a leak from the lateral injury. So that is lateral. E is circumferential injury of bile duct. Okay, circumferential injury is E. So don't forget Strasbourg classification. The most common type of injury is this. This is an image from Bailey and Love. This can come for you as an image-based question. What is this classification shown here is Strasbourg? A is cystic duct leak. B is aberrant duct clipped. C is aberrant duct cut. D is lateral injury. E is all circumferential injury. All E is circumferential injury. So don't forget this classification, classical classification. This can come for your exam as an image-based question. What is the name of this classification? Mr. Somu, 25 years old alcoholic male, was admitted in ICU for severe acute pancreatitis. CT abdomen was shown on 4th post-operative. Can you see what is the finding in the CT? This is the pancreas. What happened to the pancreas? This is spleen. You should be able to identify the structures in a CT abdomen. This is a pancreas, and this arrow shows a black thing. What is that black thing? That is a loss of blood supply to the pancreas causing necrosis. This is a concept on pancreatic necrosis. So when you see a pancreatic necrosis, we should go for a step-up approach. The approach we should do is step-up approach. That is called as pancreatic approach by step-up method. CT shows pancreatic necrosis. Percutaneous drainage is done first. I will put a tube and drain this first. That is first step, PCD. If sepsis worsens, then through the percutaneous tract, I will open that tract and remove that. So then, if it is still bad, I will do by minimally invasive surgery, like laparoscopy, or I will go for open surgery. So this is the question. So the question is, percutaneous drainage of the infected fluid must be drained by a PCD tube. That is correct, which is not a part of management. If sepsis worsens, I should do necrosectomy. Yes. If the head is involved, a retroperitoneal left flank approach is used. Please understand, here is a catch point. This is the pancreas. Necrosis can happen either in the head or in the body and tail. If it is in the head, I will go via the trans-abdominal approach. In the head is here. So go by trans-abdominal laparoscopic approach. If it is in the body and tail, I will go by a retroperitoneal. Body and tail is here. So I can go by a retroperitoneal approach. So necrosectomy is done either by laparoscopic or retroperitoneal. Head necrosis approached by laparoscopy, body and tail approached by retroperitoneal method. And for patients who are having severe necrosis, we can even do a open surgery like this and keep a drain like this and another drain like this so that I can wash like this. This picture is there in Bailey and Love. So open necrosectomy and continuous lavage, that is called as Beger's procedure. Beger's lavage procedure. This also can be done. So therefore, the answer here wrong is C. If head is involved, a retroperitoneal left flank approach is advised is wrong. Okay, it is for only body and tail. So just have an idea about necrosectomy. So you have to, when I'm doing a necrosectomy, simultaneously I will do a feeding jejunostomy. If there is a gallstone, I will do a cholecystectomy, or I will do a closed continuous lavage, closed drainage, open drainage, or closure and re-laparotomy every 72 hours. All these are various options available for pancreatic necrosis. Okay, question number 17 from urology. You can see I have touched all the chapters. I never missed to touch any chapter. 20 questions are taken from 20 different chapters in Bailey law. So now we are coming to urology question. Mr. Mishra, 40 years, male with a stone in the renal pelvis. Size of the stone is 2.5 centimeter stone. 2.5 centimeter stone, and the stone is planned to be removed by PCNL. Surgery was done successfully. Regarding PCNL procedure and complications, wrong statement. After conclusion of procedure, a nephrostomy tube is kept. Yes. After completing the procedure, we temporarily keep a drain like this. This is ideal procedure for patients who are having diverticulum in the calyces. These are the calyces. Yes, calyceal stone, this is ideal. Hemorrhage from the renal vessels needs to be repaired by surgery. No. What will I do for a hemorrhage? If I puncture, you can think it is a percutaneous nephrolithotomy, is a blind procedure. If I perforate the renal artery, what will I do? I will go for angioembolization. Doesn't need you out to operate. Injury to colon is a complication of subcostal approach is true. So the answer here is you should understand what is percutaneous nephrolithotomy. So this is a kidney, okay? This is a kidney. You can see this is a kidney here. So kidney is like this. This is a stone here. I have to go by a small hole, either subcostal approach or transcostal approach. And I have to widen the tract and break the stone and remove it. That is known as PCNL. PCNL is ideal for stones more than 2 centimeter, infected stones, obstructed stones, staghorn stones, cystine stones. In all these stones, PCNL is best. If I go by subcostal approach, that is colon and duodenum can be injured. Colon and duodenal injury can happen. Transcostal approach, pleural and lung can be injured. So that is a very simple concept. Okay. So the question is asking, last point, injury to the colon is a complication seen in subcostal approach. This is a picture showing you various scope images. This is a 2 types of scopes. You can see this is flexible ureteroscope. This is rigid ureteroscope, which can go into the ureter, which is 6 mm diameter. This is a picture showing you cystoscope. So cystoscope, rigid cystoscope. There is no flexible cystoscope. We have only a rigid cystoscope. This is nephroscope used for PCNL. This question can come for your exam. So what is the use of this scope? This scope is single hole we are going to enter inside, and through this I can see eyepiece, and through this I can operate. So one hole, I will remove the stone. This is nephroscope from Bailey law. So complications of PCNL, hemorrhage from renal parenchyma from major renal vessels. If later occurs, the treatment of choice is embolization. But if this doesn't work, nephrectomy has to be done. So please remember, hemorrhage from the renal parenchyma, we will go for embolization. Coming to the 18th question from TURP related question. Mr. Ganesan, 70 years male, underwent TURP in urology department in a government hospital. That is a very important point, because in government hospital during TURP we use distilled water only. We don't use isotonic glycine. Ideal fluid is isotonic glycine is not used in government hospital because it's very costly. Therefore, we will, yes, if little concept oriented question, just have an idea. But all the concepts are very important. Our question is little tough, but all are concept oriented. I want you to know the concepts. Don't worry about the questions, understand the concepts. So this question is related to TURP and its complications. This is that each one is one MCQ. Following a TURP, a patient has confused status. What is the reason? Just remember the question, answer. Post TURP, patient, you are going for an evening ward rounds. PCNL only lepro means? I could not understand your question. PCNL only lepro, I could not. Confusion status, answer is what? Confusion status is due to water intoxication, because I have told you, I used distilled water. Distilled water will enter the bloodstream and cause hyponatremia. Okay, hyponatremia. Dilutional hyponatremia. So one is A. Retrograde ejaculation, very, very dangerous and worst complication. The old man will kill you. What injury? Retrograde ejaculation is due to external urethral sphincter injury. Sorry, internal urethral sphincter injury. So this retrograde ejaculation is due to internal urethral sphincter injury. So what is the problem with external urethral injury? Very, very dangerous complication. This is 3, incontinency. They cannot control the urine. Okay. PCNL is like laparoscopy. So laparoscopy, laparo means abdomen. So like PCNL is same like laparoscopy. Okay, it is like laparoscopy. Yearly rigors following surgery is due to septicemia, bacterium. So the answer 4 is A. So the answer here is 1H, 2E, 3D, 4A. So little difficult to answer, but I want you to know the concepts only, that's all. So let me draw the anatomy of prostate. This is internal urethral sphincter. This is external urethral sphincter. This is the prostate. I am going to remove this prostate by transurethral method. So when I am removing by transurethral method, if I injure internal urethral sphincter, there will be retrograde ejaculation. If I injure external urethral sphincter, there will be incontinence. So which is very dangerous. Incontinency is very dangerous because old man is least bothered about retrograde ejaculation. Therefore, when I am doing TURP, I will stop at this point. If you are telling this point, that's enough. This is the distal limit of TURP. Anybody, what is this point? Distal limit of TURP. This is, see, I'm discussing concepts of questions, but MCQ points are there in each concept. What is this? The distal limit. When I'm going to remove this, yes, very good, Aladivinath, that's absolutely correct. Verumantenum. Verumantenum is a NEET PG question. The point I should stop dissection is at verumantenum. I will not go beyond verumantenum. Normal saline should not be used. In government hospitals, we don't use normal saline because when I'm using diathermy, normal saline will not properly make me cut the tissue. Normal saline can be used, but problem is, if I'm using normal saline is an excellent conductor of electricity. If I want to cut this tissue, it won't cut this tissue because normal saline is present here, will divert the current everywhere. Therefore, normal saline is not used during surgery. But normal saline is the fluid of choice after surgery. After surgery, for irrigation, we use normal saline only. Don't forget this point. Very interesting point. So stop at verumantenum. Very good, Nitya, Shubha, Nitesh, Aqua, everyone correct. So please remember, last point of irrigation is at verumantenum. So 19th question, false statement regarding varicose vein management by recent advances. See, the 2020 series was made in such a way by Doctutorials that the session has to be completed in 1 hour. So we want to give 20 concepts in 1 hour. So therefore, we can revise all the 20 subjects in 20 hours. That is a plan. So that is why I'm little fast. Hope those who have already prepared, this will be a recall for you. So varicose vein nowadays managed by radiological method by using either endovenous laser or endovenous RFA, which is costly. RFA is costly. Please remember, RFA is costly. Laser is cheaper. Laser can be used for dilated tortuous veins. Dilated tortuous veins, you can use laser. So dilated tortuous veins, RFA is not helpful because it will not go so curved. So laser is best for dilated tortuous vein. But problem is, laser needs training, needs pre-checkup training. So much of learning curve is needed and safety precautions are needed in theater. But whereas RFA does not need any safety precaution. Easy for beginners. And nowadays, RFA is the best compared to laser. Compared to laser, RFA is best. I have made a table like this. Please go through this table. RFA cannot pass tortuous vein, cannot treat perforators, and costly. These are the disadvantages of RFA. But advantages, it is easy for learners, less procedure time, no safety protocol needed, reduced pain and bruising. So these are the advantages of RFA. Therefore, many of us are using RFA in practice compared to laser. So this is one method of creating foam method known as 𝗙cie method. So 𝗙cie method is a foam injection for varicose vein. Even this is replaced now by RFA and laser. So you can see now finding the varicose vein, the radiologist will put the injection and make a tight compression for the varicose veins. So question number 2, a last question for discussion from plastic surgery. Question number 20, identify the correct order of the flaps. Just tell me what is the name of each flap. This is called as, A is rhomboidal flap, also called as Limburg flap, already asked many times, used in pylonidal sinus. Pylonidal sinus. So this flap is used in eyelids, called as bucket handle flap. Like a bucket handle. If upper eyelid is gone, I will turn the lower eyelid up. That is called as bucket handle flap. So this is advancement flap. Yes, advancement flap. This is bilobe flap. Bilobe flap. For nose, if the tip of the nose is gone, we can make a bilobe flap. So the choices are Limburg flap, bucket handle flap, transposition flap, bilobed flap. From all the images are from Bailey. So these are the various types of random pattern flaps. So random pattern flaps are the flaps which have no named arteries, no named blood vessel. What is opposite of random pattern flap? Anybody? If these are the random pattern flaps I'm discussing here, like this is a transposition flap, this is a transposition flap, this is 𝗨 is a type of random pattern flap, this is rhomboid flap is a random pattern flap, this is a Limburg flap or a rhomboid pattern flap for a pylonidal sinus, this is another rotational flap similar to rectangular rotation, this is a circumferential rotation, this is VY advancement, rectangular advancement flaps. This is a 𝗵𝐵𝑐e flap for lip advancement flap. This is an interpolation flap. When the finger is gone, you can keep the finger stitched to the groin, and afterwards you can use the groin tissue to cover this finger. So all these are called as random pattern flaps. All these are random pattern. My question is, what is opposite to random pattern flap? The flap. Yes, very good. Aqua 999 and Mohammed Salman. That is correct. Axial flap is a name opposite to random flap, which has a named artery, like PMMC flap, tram flap, delta pectoral flap. All of them have a named artery. So this is a bilobed flap shown here in this image. This is a bilobed flap. This is a bucket handle flap. This is rotation flap. All these flaps are there. So please go through the videos in the YouTube channel for free. It will be there. This video will be available. Anyhow, stick with your schedule. Just 1 hour we are giving free revision session. Please utilize the session. Try to attend this session after completing the MCQs from the app. Then only you'll have an idea of what mistakes you are making. I purposefully made this 20 questions more tougher. So even if you get 10 mark out of this 20 questions, it's a good score only. Don't worry about the score. I hope you all learned some extra points during your last minute. So all the best for your NEET PG exam. There will be no more session until NEET PG because we don't want to stress you guys with so much of points at this point of time. Just revise whatever you have read. That is enough. Okay. Thank you all. You can follow me on my Instagram. 𝗙cie𝗰𝗧𝘂𝗊 is the name of the Instagram channel where you can see hundreds of surgical videos which can be helpful for your exam. Thank you. Thank you. Thank you all. Thank you. Thank you, Shubham. Yes. Thank you all. Thank you, friends.